Okay, I know there will be some people that'll show up at, is this working? Yes, everybody's happy with the sound. We'll go on and get started. I want Lester Moorhead to show up, so I hope he carries his little self over here from clinic. But anyway, okay. So I know Dr. Greenberg and I always talk about conference attendance, so I figured this was a good way to get you all here so we can talk about the flu. Haha, not really. We really are not talking about the flu. I don't know anything about the flu. I don't have any disclosures. I got a little laugh. I'll take the laugh at least. But we really are going to talk about sexual health in women. We're going to talk about some techniques for assessing hypoactive sexual desire disorder, medical conditions that are associated with sexual dysfunction in women, and then existing and upcoming therapies for desire and arousal disorders. I also hope, and I kind of think that sometimes people choose internal medicine and they think anything that is related to the crotchal area is going to get referred to GYN, but I can't really think of a general medicine or any subspecialty of medicine where you would not be doing your patients a disservice to ignore this stuff. So you do take an oath to do no harm, so you might at least be aware of these medicines, and if your patients are taking them, whether they're harming them or potentially helping them, and at least have an open mind about talking about this stuff when they come to you. And if there is something that you haven't done a pelvic exam in years and that's just not going to happen, then that's one thing. But if you shut down the discussion before your patient even gets to talk about it and you say that is somebody else's territory, then they may not bring it up again if they get shamed once. And I know none of you want to do that. Also, this stuff is on MixApp and it's on board prep stuff and on your boards now. So those of you preparing for the medicine boards, they want you to take care of the whole patient, not just their diabetes and hypertension. So just have that on your radar. Okay, now I feel better. So we're going to talk about, there's arousal, which is totally different than desire, and so you kind of have to put those in two different pockets in your brain. Arousal is all the autonomic stuff that happens in response to some stimulus, whatever that may be. And then there's some physical things that we can find that happen with this stuff. But it's important to realize that none of that necessarily correlates with a woman's level of what she perceives as exciting. So all of these things can happen, and she may just be thinking about her laundry or whatever else is on her mind that day. So Dr. Cherafata has got a sad look on his face after hearing that. So we're talking about different things. All of those things may be happening and she's still not satisfied with the experience. We don't really understand all of these things very well. We think there's some nitrous oxide stuff, and there's all these things about melanocortin-4 receptors and oxytocin and all these things that I'm not smart enough to figure out, and I'm not going to try to figure that out today. So just realize that we don't really have a great understanding of all of this stuff. For those of you who ever, I don't know, a lot of you guys were probably born way after this, but if you watch this movie, you kind of realize that this is a sought after thing, but orgasm is a brain event. So there are physical things that happen in both men and women when they have an orgasm, but it's really a brain event that's triggered by lots of different things. So when you're talking about sexual dysfunction in men and something is either up or it's down, that's different in talking about it in women where you're talking about something very subjective. So it's a little bit, I'm not going to say harder, there's going to be lots of words I can't say in this talk, a little bit more difficult to deal with. So this is the normal human sexual response cycle. There's desire, and then we talked about arousal. There's this plateau phase, that's this brief time period before orgasm. then orgasm, and then resolution. So that's the basic stuff for those of you who went to Catholic school and you got everything blacked out. Barlow's model of sexual dysfunction has been around for a while, and this is basically just saying that if you have a positive experience, then that feeds back, and you tend to think these are going to be positive things that I'm going to have happen. If you have a negative experience, if there's some pain or if there's something, and then you anticipate that the next time, it feeds back and kind of keeps making this little loop. So instead of your autonomics going and helping you and making you have a good time, your autonomics are working against you and stressing you out. So that's kind of the model for some of these people. Just get into kind of habituated to think this is going to be a negative experience, and so it works against them. Prevalence of impaired sexual function in women is a reported 58% of women in the past year, so more than that of depression, social anxiety, and some other things. But we don't really know this. This is a lot of people that probably have some transient experience that is negative for them, and they get over it and they never talk to anyone about it. So I would imagine it's higher than that, just because I just imagine that. But I'm going to be focusing more. When you're taking a history, you're looking at, are they having a desire or interest issue? Are they having some sort of arousal issue, orgasm, pain, or vaginismus? I'm focusing more on the desire and disinterest stuff today because it's a lot more than what I think you can cover. And I'm certainly not an expert in this, but I was interested in learning more about it, especially when I give the women's health lecture for the board review course, and some of this stuff comes up in MixApp. I'm always just thinking, I don't know why I'm teaching this because I don't know that much about it. So I wanted to feel a little more educated when I was talking about it. Okay, so the definition of this HSDD, or hypoactive sexual desire disorder: persistent or recurrent deficiency or absence of sexual desire or receptivity to sexual activity, and this is important, that causes marked distress or interpersonal difficulty. So some women don't really have that much interest in sex, and they sleep in separate bedrooms from their significant other, and they really don't care. They do not have this disorder. But some women perceive that they think they should be more interested, or they're not interested like they used to be, and then it's stressing them out and it's causing problems in their relationship, and so you could consider this. So you're wanting to look for at least 6 months of this, so it's not just they had a bad time once or twice and now they're kind of a little stressed about it. You want them to have persistent reduction or absence of fantasy, sexual interest, responses to their partner's initiative, decreased response to external, internal sexual cues. They may miss out on that excitement or pleasure portion of stuff even though they're aroused. They express that there's a lot of distress about this, and they really are having trouble in their home life and that kind of stuff. And you ruled out other causes for their problem. So why does this come up so much? So some women are probably okay with growing older and realizing that they're not going to have the same type of drive that they did as a young person, but their husband went in and got a bunch of blue pills, and now they want to have this pounding stuff happen, and their body is really not into that anymore. So there are these, Prevention Magazine had one article about it saying, I was okay with this, but my husband was going through kind of a crisis and went and got these pills, and now that everything's out of balance and there's no medicine for me to take to keep up with him. So it's definitely created about 26 medicines out there on the market for male sexual health issues, and really none for women that are FDA approved. There was an article on what causes the stress about this, and some of the women were stressed out because they physically, or they themselves were missing out on the pleasure of stuff, and some of them were distressed about their partners. and the impact it was having on their relationship. So when you're talking about the lack of desire with the marked interpersonal stress, you have to kind of use your intuition a little bit to decide if it's how big a deal is this. So some of these are going to talk about premenopausal women, and some are talking about postmenopausal changes, but there are just along the natural course of things, hormonal changes when you lose gonadal hormones and physiologic changes, and then social changes that happen along the way when you're getting older that are going to put more stress and what can take away enjoyment from your life if you're going through a divorce, if you've lost your significant other and you're starting over dating and that kind of stuff. That's something that a lot more people are going through, especially as we live longer past menopause than women used to. So I put a few medical problems that we're dealing with on a pretty regular basis. Women with diabetes are more likely to report sexual dissatisfaction, so our endocrinologist cannot escape this talk, and I know Dr. Levine probably loves it a whole lot. You can't always correlate their glycemic control with their level of dysfunction like you could maybe with males with erectile dysfunction. And then if you have diabetes and depression, there's a link there too with sexual dysfunction. They do have similar rates of decreased desire to women who don't have diabetes, but they're more common to have problems with arousal and lubrication, maybe because of vascular complications and stuff. I'm going to keep going. So there also may have some neuropathy kind of issues that could impair sensation in the clitoris, the labia, and the vagina, as well as in non-genital sites. So on top of the vascular stuff, if their nerves are not acting right, they could have some impaired sexual function. Women with metabolic syndrome, they may have just a negative, they may just have some self-image problems. This is more of a problem in premenopausal women than postmenopausal women. I guess as you age and start to accept your body a little bit more, you don't care so much about that stuff. In women with polycystic ovarian syndrome, there's not a ton of research, but they already have some issues with their hormones to start with. They did have, there was a study that I read up that showed some improvement with metformin as far as their psychosexual function too. So that may be another reason to consider doing that early on. And then thyroid disease, so it makes sense that if your thyroid isn't really doing what it's supposed to and you don't have any energy for sex either. Hashimoto's patients can have decreased desire, arousal, and lubrication. Multinodular goiter patients can have issues too. And then this FSFI, I'll talk about in a little bit, is a female sexual function index. So there was an inverse relationship between their TSH and their FSFI. So the more hypothyroid they were, the cruddier their score was. Then another one, birth control pills may have a positive effect because you're not so worried about getting pregnant and maybe it's helping with other symptoms you were having like menorrhagia, but it can have a negative effect on your sex drive with its effect on testosterone. I think it's a good idea when we talk to patients and we're doing their pre-op thing, and now pre-op evaluations have gotten pretty streamlined, and if you all are reading your little peak module that Dr. Kelly assigned, then you know this too. It's super easy, but if they're coming in for a hysterectomy, if there's not a really clear indication for why they're getting it, I think it's important to talk to them about what may be coming when they get this, that if they just are doing it for some pain that they might be able to live with, it might be worth talking to them and saying, what have you thought about what's coming afterwards? You're thinking about getting rid of the pain, but is it mild enough that you could go about your daily life and still have a good quality of life versus having a major surgery and then having these, hot flashes and all the other things that are coming with it, and then possibly affecting your sex life too. When the patients that were taking hormones for this, if they were taking testosterone, I think I put this in the wrong slide, they did not observe effects until after taking that for 4 to 16 weeks. So that's a long time to ask somebody to wait out a medicine to me. I put that in the wrong place, sorry. So your initial approach to somebody with possible sexual dysfunction, you're going to take a sexual history during your review of systems, and you can have something that a patient fills out ahead of time if you want to let them know, hey, there's going to be, this is an okay place for you to talk about this stuff, and put it in their brains, depending on what you're doing. That would let them know that you're comfortable speaking about this stuff. This FSFI that I mentioned before, it's a validated 19-item questionnaire that's subdivided into 6 domains: desire, arousal, mental arousal, physical arousal, orgasm satisfaction, and sexual pain. And this was developed by a drug company, so take that as whatever you want to take it as. Some of the questions on it are pretty clear. How many times did you have an orgasm over the past month? Did you have any pain? Those kinds of things. But the first question gets on my nerves, and it says, over the past 4 weeks or over the past month, how often did you have sexual thoughts? Always, almost always, sometimes, never, almost never. It's very, basically, if you are a woman who does not walk around and get anything else done during the day but think about sex, you automatically have a lower score on that question, and that bothers me. Some of it is a little bit sneaky to me. And then if you get less than a 26 on this score, you're supposed to be at risk for sexual dysfunction. So it's something you can use, and it's something that they use in a lot of these research papers, but after having read a lot of this stuff, I don't trust any of these drug companies. Well, I didn't before, but now I really don't. When you take your history, you're going to look for religious and cultural factors that may be affecting things. I didn't put any specific examples because every example I could come up with seemed offensive in some way to some culture, and so I didn't do that. But if you don't know somebody's culture or background, I'm a big fan of just asking, are there any things in your religion or culture that you think might be affecting this, and let's talk about that. And I might not be the most aware of things in the world, and I know I'm not, but I'm at least willing to talk to patients and ask them where they're coming from, and that can help maybe avoid a medicine entirely because you find out that they've just had a lot of shame growing up, or there's something else that's going on. You want to pay attention to medications, and we'll talk about those in a second. Their surgical history, their social history, and their psychiatric history. Bunch of the medicines we use are on this list, so you want to, most of our blood pressure medicines you want to pay attention to. Some of the antidepressants are on there, especially the SSRIs. So those are ones to pay attention to. If you have somebody on an SSRI and their main complaint, they say my depression's better, but my sex life is still no good, you want to tease out whether that's because they were depressed and they already had some baseline sexual dysfunction, or if it really is the medicine. And you have the option to decrease the dose and see if that would help. You could switch to another antidepressant, Wellbutrin, if it's not contraindicated because of blood pressure reasons and seizures and stuff. That's an option. And then there's a new one out called Vilazodone, which is it's a new SSRI that's touted as not having the sexual side effects. So if they can afford a new fancy medicine, then that would be an option. If they had a previous suicide attempt or some other reason that you really don't feel comfortable taking them off of it or switching their medicines, then I would send them to psychiatry and say, I really need help picking a good antidepressant that they're going to be willing to take that won't compromise their sexual function and also won't put them in the hospital for a suicide attempt. So the physical exam is where some of us get a little hesitant because we just thought that pelvic exams were long behind us, but what you can do your basic, all of your good internal medicine stuff and look for things that would make you think about anemia, thyroid issues, connective tissue disease, Any disabilities that may make it difficult for a patient to physically manipulate things and have an easy time with intercourse. If they have catheters or stomas or something else that may just be kind of an issue for embarrassment or physical barrier, that's something to think about. And then you want to do a good GYN exam. Some of this stuff when I was reading, I wasn't really sure if I would pick up on it because I don't do pelvic exams all day long, but I think it would be reasonable to at least look for obvious signs of chronic candidiasis, if they have a rectocele or something else that I would feel silly sending them to GYN without having done it. The same thing when my husband gets consults for ear pain and there's no ear exam documented, that internist looks really silly. So I don't think that I'm necessarily going to be the expert at this, but at least an external exam where you say, yep, I don't see anything, and maybe a bimanual exam to make sure they don't have some big tumor or nodule of some sort, because I would also feel like a bad doctor if I sent somebody and what was causing their pelvic pain or their issues with sex was a big tumor coming out of their cervix. Seems like you don't want to wait for their appointment in a month with GYN for that to get discovered. So it doesn't take that long really to do these things, and I know I'm not going to get buy-in from everybody on that, but you can think about it. There's not really necessary to do lab testing for most of this stuff. You can check hormone levels, but the testosterone level stuff, there's really a wide range of what's normal, and you're not going to, as far as I can tell from talking to a couple of my endocrine friends, there's not really a range that you even know what to do with. And then the lab test, as far as I read here, and they might confirm this, does not catch estrone, which is the one that you're looking for in older women especially. So it may not really be that helpful to do lab testing other than to make sure their thyroid's okay and they're not having prolactin issues or those kinds of things. I'm going to switch gears a little bit because one of the things that got me motivated to read about all this stuff was seeing what the drug companies are doing to convince us that this is a disease. I don't want you to think by any means that I'm saying that women don't have problems with their sex lives or have distress from it, but I don't know that I would really necessarily always label this a disorder or a disease or feel that I needed to give somebody a prescription for it. So a couple of things. There's this condition branding, which is a marketing technique where a company adopts or in some cases invents a condition and then develops this disease state before they can even market the drug that they want to market. They can start putting the disease into CME activities and board prep and get doctors on board to teach about it and do all these things. So you think, this is terrible, these women are having all these problems, there's this disease and we're not doing anything about it, what can we do? I have a couple of examples of other things that they do. So you could take Prozac for a while, and it was 20 milligrams, and you have this capsule, you can deal with your depression, and then their money's about to dry up and they're going to have to go generic. So they come up with Seraphim, which is exactly the same 20 milligrams of fluoxetine, but now you can use it for premenstrual dysphoric disorder and not just depression. And a woman doesn't have to say, I'm taking Prozac for my PMS. They can come up with the pretty pink and purple pill instead. So that's probably an easy one to realize and see that we're getting sucked into something when they could take a really cheaper version of that and not spend money on a prettier pill that they're just going to swallow and digest anyway. They may take an existing condition like heartburn and then say, we got Zantac coming, we got to convince people that heartburn is terrible, and we're going to call it gastroesophageal reflux disease, and we're going to give it research grants so these GI people can get papers, and they're going to look fancy, and we're going to launch this public relations campaign, we're going to let doctors on board, we're going to talk about GERD, and then they come up with Zantac. Yay, there's this new medicine for GERD, which is terrible, it's a terrible disease. But really, maybe they just are overeating and drinking too much alcohol and smoking, and there's lots of other things you could do besides a pill. You can redefine an existing condition to reduce the stigma. So if you're going to come out with Viagra and nobody wants to go to the doctor and have impotence written all over their chart, they might be okay with having erectile dysfunction as a medical condition written on their chart. So they recast it as this whole thing. Nobody's laughing at this slide. It's making me sad. Think about it for a minute. But so you get recast as this medical condition rather than something that maybe is a psychological thing or just a normal effect of aging. We had this Pfizer had physicians promoting the drug and the disease. They paid researchers to publish studies about the prevalence of erectile dysfunction. They tried to get men who had just transient problems with not getting an erection to take this medicine. And then one physician that was paid by Pfizer said all these men should just take it as prevention for erectile dysfunction. So you just have to put that in your head when you start seeing new things come up. And when I'm seeing stuff, teaching the board review stuff, and all of a sudden there's a section in MixApp on hypoactive sexual desire disorder, I'm thinking, I have never heard of this, ever. And then when you just start thinking, oh, this is just a woman with decreased libido? Okay, did we need a section in MixApp about this? Do we need questions to denote? I don't understand. So when you time these things and you start putting a bunch of publicity out there and the public's hearing all of these things and this disease is terrible, and why don't you doctors do something about this, then it gets kind of messy. So the title of my talk came from Valentine's Day, and I have a good friend whose boyfriend conveniently does not believe in Valentine's Day and therefore has gotten out of years worth of presents for this, which is he's maybe a genius, but are we, and then I love Amy Poehler, so I have to put that down there. Are we inventing conditions so that we can make some money off of people buying a bunch of stuff? So I'm not saying that women don't need help with their sexual health, but I'm going to talk about some of the management that we have and then what's coming. And there's a big push, and there's a bazillion things that are being developed to try to get some money out of this. And you just are going to have to decide when women hear about these new treatments and they come in and say, I heard there's this new pill, I want this female Viagra, whatever it is, I don't care how it works, I'm willing to try it. And you need to help them decide if it's going to help them, if it's going to work for them, and if it's going to be something that could cause harm. So the real Viagra, sildenafil, is sometimes it's not FDA approved to be used in women, but you probably realize that people go all over the world to try to get stuff they're not supposed to have, so some women do take it. It's thought to increase pelvic blood flow to the clitoris and the vagina, similar to what men with erectile dysfunction experience. There have been some trials that say, okay, yeah, that did help, and then some that didn't, so not great, not good enough information yet, so we need more information to feel like we can prescribe that one. But this new one, the female Viagra, is a misnomer. It doesn't have anything to do with whether something is up or down or has blood flow or doesn't have blood flow. It's working on the prefrontal cortex of the brain. So it's working at this 5-HT1A postsynaptic. It's an agonist for that. It's an antagonist for the 5-HT2A receptor. It works on dopamine and norepinephrine. So it works on a few things in your brain. It was originally going to be an antidepressant, but then when that didn't pan out, and I guess some of the women who were taking it in those studies said, I don't know, I'm really depressed, but I'm getting a lot of action. Maybe they said, well, we'll try that. So this is, the name of it is flibanserin, aka Viagra for women, and she's saying, I'm a smidge randy, also nauseous, sleepy, and dizzy, and progress marches on. So this company, the original company who was trying to get it marketed as an antidepressant, ended up selling it, and then there were 3 attempts to get it FDA approved by this Sprout Pharmaceuticals, who launched this huge campaign. The brand name of it is going to be, I think it's Adyi. I don't remember how they were pronouncing it. They launched this huge campaign They had a meeting in Cape Cod where they got all these doctors who had worked with drug companies before to come out there, and people that write the DSM-4 and now the DSM-5. And if you weren't willing to work with a drug company, you didn't get to go to this fancy party meeting in Cape Cod and develop this stuff. So they wrote a definition in the DSM. They came out with all this definition of hypoactive sexual desire disorder, and got these 4 congresswomen to write a letter to the FDA about it's terrible that you're not prioritizing women's health, and there's 26 medicines approved for male sexual dysfunctions, and we have none. And so they get all these people on board, and there's a whole website called Even the Score where they talk about all this stuff. So they're getting some people pissed off. So you just be aware of what's happening out there, because people are going to come in and ask for this stuff. It's a non-hormonal medicine, so people may come in and say, I didn't want to take hormones, but I can take this one, and maybe it'll help me. There was a trial that they did for it, and I like this quote: it's hard to see what's sexist about the National Drug Regulatory Agency refusing to approve a drug that was ineffective. So they went back for the 3rd time, and they had this study where they had 1,700 women, and then they randomized about 1,000 of them to either placebo or flibanserin, and then had a good chunk of those complete the study. And they did have a difference between placebo and the flibanserin, but you can see if they started off at week, on the bottom graph, they started off with their frequency of sexual experiences over 28 days. If they had an average of 1, it went up to 1.5. And on down the line, you see it maybe went up by a half or 1 per month. Wow. No, I'm not really sure I would be all excited about that. I think I could find some other ways to get some results. And their side effects that they reported were dizziness, insomnia, nausea, and headache were the most common. So nothing, nobody died. They had 1 person in the placebo group and the other in the drug group, both with a suicidal attempt, but it was the same, 1 in each group. But I still don't know that it's worth even spending any money on that. A few other things. There's a bunch of herbal supplements that are all over the internet. I picked one of them called Provestra. It's got a bunch of junk in it. I have no idea what is actually in it because it's not FDA regulated. Maybe they're getting the iron and they were anemic and they have some energy now. I don't know that. These are things that people may be getting off the internet. They don't need a prescription. They can order all of this, and there's a few of them that are like this, and probably more than what I found too. It's important to ask about what people are taking, not just prescription stuff, because they may be taking this kind of stuff too. As far as testosterone in women, there's a modest variation during the menstrual cycle, and then your total and free testosterone decline progressively with age. And there's a wide range of this, so whether you can even use testosterone levels before and after treatment with it are kind of confusing to me. Should testosterone be replaced? It's not FDA approved for this, for use in women, but there still are pretty, I think I read 20% of testosterone prescriptions are filled by women. The transdermal forms have been shown to be effective for short-term treatment, but for not shown yet for long-term treatment. So if you wanted to use it for a little while, then that would be maybe a consideration if you wanted to use it off-label. The endocrine people, who are, in my book, pretty smart, say we recommend against the general use of testosterone for infertility, sexual dysfunction other than hypoactive sexual desire disorder, cognitive, cardiovascular, metabolic, or bone health, or general well-being. They say you could use short-term treatment with it. Endogenous testosterone levels did not predict a response to therapy. And we don't have these forms available in the U.S. This testosterone matrix patch, I'll show you that in a second. And we don't have long-term safety information. So in this Endocrine Society update, they said 3 to 6 month trial you could try, and you wanted to measure testosterone levels at their baseline, and then after a few weeks of treatment, you could check it again and see if they're using it too much. They did talk about in one of the articles that's the ACOG practice guidelines on sexual dysfunction that they don't recommend checking testosterone before or after treatment is started at all. So a little bit different, but I erred on the endocrinology side because they're the smartest people I know. So, and then they say if you haven't responded to treatment by 6 months, then go on and stop. This is the little matrix patch. This has been well studied in other countries, but we don't have it here. It's just you have your skin and then a little protective liner that you take off, and then there's the drug, and then there's a little film backing on it. Some things to look for: hirsutism. So you may cause some extra hair growth. The women in these studies that had problems with this didn't discontinue the drug any more than the women that didn't have problems with hirsutism. So I guess they figured, I'm a little bit hairy, I can shave that off, but I'm having fun otherwise. So they were willing to deal with that. Acne, they didn't have any more problem if they were given, they had less than 10% of patients treated with testosterone had it, and then if they gave estrogen along with it, didn't really make any difference. And then virilization is uncommon at these doses, so mainly, and I did that on purpose with the slide to get you all to tilt your heads because don't ask me, Jennifer Kelly was laughing at me. Mainly you would see this in super physiologic doses. It was interesting to me to read for the cardiovascular risk, decreasing their HDL, increasing their total cholesterol to HDL ratio, but decreasing their triglycerides, and then I think increasing their LDL. So these female to male transgender patients that are taking really high doses of this stuff, their risk of MI, hypertension, and death was no higher than that expected in the general male population. So we do have patients that are taking pretty high doses of testosterone and get to see what's happening there. Okay, there is a battery-powered device. It's not a vibrator. It's applied directly over the clitoris to create a vacuum to increase blood flow and engorgement. It was on Amazon, but it's not currently available, but I think you could write your patient's prescriptions for this. I think it's called Eros, E-R-O-S. They might have to shop around a little bit longer for that because I couldn't really find an easy way to get it with Prime. Will hormone replacement therapy take care of all this? No, you can use topical estrogens to help with lubrication, and that may help with some postmenopausal atrophy, with physical discomfort, but oral forms don't help with this stuff, and you can use oral estrogen for hot flashes and that kind of stuff, but it's not going to necessarily fix their sex life. If you think about this, Jennifer made a good point. If these women were having problems before they went through menopause, then it might not be related. It's not necessarily related to their estrogen levels at all. So it makes sense. There's some studies on alternative therapies for this, and when I first read about this acupuncture thing, I was a little worried about where they were putting the needles, but they're all over the body, not necessarily in delicate places. That was more studied with regard to pain and not just desire and arousal disorders, though. Okay, so there's a bunch of new medicines that are coming out, and these people are just working overtime to try to see who's going to get some money out of this first. The one that seems like it's going to come out first is this bromelanotide. It's a sub-Q injection. It works on this melanocortin hormone pathway involved in the arousal response that we kind of mentioned briefly earlier. That one is so far well tolerated in clinical trials. They had some patients had some facial flushing, nausea, and vomiting, which were mild to moderate. And I think that's finishing up phase 3 trials right now. So there's that. Femprox is this topical alprostadil cream. That one I think is kind of on hold in trials. It didn't really go past the phase 2 portion as far as I remember. Lorexis, they just took a couple of old medicines, bupropion and trazodone, which are antidepressants that are not known for having sexual side effects, and stuck them into a pill together. That one will probably be out a little faster since we have lots of data on those two medicines from using them for a long time anyway. So if that one comes out and your patient seems like they're appropriate for that, you might just think about giving them the cheaper, older versions of either one or both of those and seeing if that works first. I'm sure it'll be a pretty pill and come in nice packaging though. This testosterone gel, apparently there was a pretty good placebo effect when they tried to study this one, and so they couldn't show any real improvement with it. So maybe if you just, I wish we could use that more often, but the placebo effect, but I guess I'd come up with something. There's two drugs that have similar names. Librido is Viagra and testosterone. That one's under clinical trials right now. And then Libidose, which I don't know why they couldn't make these a little bit different names, is testosterone and buspirone. So they're preparing, this Emotional Brain is the name of the company that's working on those two, which for some reason that name really just disturbed me. They're trying to get in our heads too much. So those are coming. I would imagine that they're going to have to change one of those names. I'm never going to be able to keep that straight. Maybe they want it to be that way, I don't know. Tefina is an intranasal testosterone that they're working on. You have to snort it up your nose an hour before intercourse, which seems, I don't know, seems like not the best thing in the world. So that one's in clinical trials as well. A couple of other things that are probably don't need FDA approval and may help them in lots of areas of their life. Mindfulness meditation. There's small studies on this, but they're promising. They have some mindfulness-based group therapy that helped with sexual desire and other things that have to do with sexual response. So this is something people could get an audiobook of or do at home or read a book about, and it's not gonna, I don't think of anything that would hurt them to do mindfulness therapy or mindfulness meditation. This Sensate Focus you may have seen on movies or on, I don't know, different things. It's a couples-based method of sex therapy. It's one of the most studied forms of sex therapy. And it's where the partners kind of go through these progressive exercises, and in some of the things they're told not to get aroused at all and to try to avoid that. And then if they both eventually feel comfortable with the whole thing leading to sex, then that's okay. But they're trying to get you to focus on the physical experience and enjoying the pleasure part of it, and not get so hung up on if you're in that negative loop of this is a bad thing, or I've had a bad experience before and things are gonna go wrong. Then it's to try to kind of help get you out of your head a little bit. I looked on this website at the American Association of Sex Therapists or whatever it is. We don't have any in Louisiana at all. There's one in Dallas. There's a bazillion of them in Austin, and as you go further west. So I figured New Orleans would help us out a little bit, but no dice there. So there was a study that talked about internet-based cognitive behavioral therapy, and that looked promising. Those are patients that might not want to actually go to the doctor, but if they could do something online and have some privacy and not have to be embarrassed, then that would be an option too. But I didn't put a whole ton of information about that. And in conclusion, there may not be a magic bullet that will work for every woman, haha. So you may have to kind of individualize your approach to things, and then we still have a lot to learn. I bet y'all thought you were going to be a lot more excited than this after this lecture. Any questions?
How much do those drugs cost? Does Medicaid pay for?
I don't know the cost of them. There was a thing, there was a big talk about, they've got to make this a disease so that they can get insurance companies to pay for this stuff. Otherwise, why would they do that? So I'm not sure yet. I doubt Medicaid would. I don't know if they might. I don't know if they pay for Viagra. Don't they? I'm looking at Dr. Levine like he knows the answer to this. But I don't know yet.
More communicative with our patients, especially the stigma. It's just because it does seem to increase by one sexual encounter a month. But you have to take it every day. And we're supposed to tell them they can't drink.
Mm-hmm.
Well, who doesn't drink before they get a little frisky? And you may not want those people driving on the road.
Mm-hmm.
So patients, I think, need to know that, because they're going to be the ones coming and asking us the drug. And it's not the same piece one by one.
No.
Favorable sexual encounter.
No, it's just going to show a happy, smiling couple walking around. Like, it's be a montage, like a little relationship.